Our first speaker of this webinar is Dr. Rajeev Reddy Pappuru, who is the head of the patient care services at Kalam Anji Reddy campus and Kodi Venkatadri Chowdhury campus of LV Prasad Eye Institute, Hyderabad, and is specialized in vitreoretinal diseases, uveitis, and ocular immunology. His areas of interest are uveitis, trauma, and macular disorders, and he has several papers, poster presentations, and publications in peer-reviewed journals. And he would be talking to us today on step-by-step approach to a case of posterior segment trauma. On to you, doctor.
Good evening, everyone. Can you hear me?
Yes.
Can you see the presentation?
Yes, sir.
Yes.
Good. Okay. So I'm going to discuss about approach to posterior segment trauma. So we know that sclera is not an optical structure, but it is in proximity with many important intraocular organs like ciliary body, choroid, and retina. So whenever there is a damage to the sclera or posterior segment, there is a lot of implications, and whatever the visual recovery is going to happen. So we need to deal with posterior segment trauma in a stepwise manner so that we get the best recovery out of whatever may be the damage which has happened. So how do we approach any posterior segment trauma? Like any other trauma, assessment of the damage is the first thing which we need to always look at. Once you have assessed, okay, there is some amount of damage which has happened. So we need to look at, is there anything which is not seen outside? What then that we need to do that by investigating these patients. And then once we have done the assessment of all this, then we can plan the management of this. So there is an example of a case where there is a blunt injury with choroidal mounds like this. You do an ultrasound B scan, you see a suprachoroidal hemorrhage, the hemorrhagic choroidal detachment which is seen there. So when you're starting an assessment, ocular trauma score is something which we need to always remember to do. This will give us a reasonable idea about how the prognosis is going to be. So we need to assess the visual acuity and associated damage to the structure. So this is what we need to remember. And whenever you're trying to assess, try to assess in these points what all the damage which we are seeing in these patients. So whenever there is a trauma to the posterior segment, it's divided into blunt injury and penetrating injury. So in blunt injury, what do we need to assess? We need to evaluate again and treat the specific conditions. You don't have to do a scleral tear repairs in these patients. So if you look at a blunt injury, so you need to see a conditions like what we're seeing here is a macular hole which is developed, or a Berlin's edema, what you're seeing here. Or sometimes you will see a choroidal rupture. So you need to look at all the structures in the eye, even though there is no tear there. You need to look at the angle, look at the angle recession, look at the zonules for what's happening to the lens, and look at the aura for a dialysis, look at the retina for choroidal ruptures and subretinal hemorrhages, and optic nerve avulsions and posterior globe rupture. Something which you always be able to remember, identify all this in front, but except for the posterior globe rupture, which you might not be able to see that with your hand, with your eye. So in those cases, you need to sort to other clues, or maybe an ultrasound investigation to see if there is any posterior globe rupture. So next thing is penetrating trauma. So what do you assess in penetrating trauma? So again, if you have a scleral tear, so we need to know the extent of the scleral tear, how far it is gone, and is it possible? You need to assess what is the associated damage, what has happened along with the scleral tear, and how do you plan your posterior primary repair management. So these are the things which we need to look at. So if you look at this patient's fundus, you see a rupture here with clot here. But what you do on ultrasound, you need to look at what is happening here is a foreign body sitting inside. So it's not just enough for us to plan just a scleral tear repair in this patient. So we need to look at what are all the damages or associated injuries associated with it. For that, you need history is the most important thing whenever you're assessing a trauma. You need to reconstruct how the injury has happened so that you'll be able to understand what is the trauma which would have created. And then try to see with the direct inspection what is the trauma which you are able to see, and do an ultrasound B scan or a CT scan or whatever is required to assess the further damage whatever was there inside. Sometimes you might not do a complete assessment in pre-op. You may have to go for intraoperative assessment, something like intraoperative assessment. Once you have taken up the patient for a scleral tear repair. So first examine the patient before you jump in and start doing a scleral tear repair. how far the damage has happened. So what is the extent of scleral tear? So is the muscles involved? If there is a vitreous hemorrhage and retinal detachment. So always try to expose that area clearly before you go in for a scleral tear repair, and do a peritomy if required for around 360 degrees, and wound exploration is required. And if you find a foreign bodies in the anterior area, you might remove it if they're free. But if you feel that they're stuck to the globe, so you always be careful that they might have penetrated the globe inside. So be mindful of pulling them out whenever you're doing that. Be careful that you don't pull out the contents out. So coming to the principles of the closure, so we need to restore the structural integrity, make a watertight closure of the wound, restore the normal IOP, protect the visual axis always, and avoid iatrogenic damage while you're doing the scleral tear repairs. If it's a partial thickness lacerations, you can just leave them alone and suture if required if there is a full thickness scleral wounds. So lacerations of full thickness, if you don't close them, it can cause it can lead into a scarring, and it can cause a bad scars. And if you do a surgical repair, it will cause it will avoid the damage to the retinal incarceration. All these things can be achieved by doing a surgical closure of the wound. So principles of posterior closure of the scleral wounds. So where if you have an extent which has gone beyond, so what you need to do is you need to close as go by. Don't open the complete scleral exposure. You might start closing the wound from the front and keep going behind and keep exposing the area. Don't open the whole globe completely and then try to suture the sclera. Consider the scleral belt if it is gone beyond 5 millimeters of the limbus, and don't try to do a prophylactic cryo thinking that, oh, I am
1 minute left.
created a break. So you need to do a scleral cryo, then we can prevent the retinal detachment. In fact, that will make it worse and will cause a directional detachment. It will aggravate the situation. So whenever the tear is near the muscles, you try to tag the muscles and see if we can actually expose the sclera. And if you are not able to do it, you can disinsert the muscle, and you can reattach the muscle after closure of the scleral wound. Always place the belt buckle if you feel the visual prognosis is good. Not necessary that every case which has gone behind should put a belt buckle. If there is a lot of damage and the contents are out, no point in putting a belt buckle there in those conditions. On completion, well-aligned wound, watertight wound closure, meticulous closure of conjunctiva is important things. So end point of the posterior scleral wound, sometimes the wound keep going behind. Always make sure that you are not causing too much of pressure on the globe to avoid the contents to extrude out. So if you have to do that, then you have to stop there at that point of time. And treating the associated injuries after closure of scleral wound, do a reassessment again the next day. And most of these patients might need a second surgery. You might need a stepwise manner. You are seeing here the wound, closed wounds, and after that we are trying to remove the foreign bodies inside. You have an infection, there is an endophthalmitis. So all these things we might have to do it as a second stage or based on the urgency. In case if there is a vitreous hemorrhage, and try to do early surgery, even if there is not a retinal detachment, because if you wait for a longer time, you will end up resulting in a retinal detachment with severe proliferative retinopathy, which makes prognosis even poorer. So earlier surgery than later is important in trauma. The take-home message is assessment and documentation, and proper
1 minute
wound
over.
closure and reassessment doing a stepwise manner is important. Thank you.
Thank you very much. That was a very crisp talk. Srinivas, could you ask your
Very nice presentation. Quickly, you covered most of the points, Rajeev sir. I just wanted to know actually when do you use the endoscopic vitrectomy? Do you, of course, you have endoscopic vitrectomy, so you prefer doing that, or if people don't have it, do they think that they are really missing that machine, or it is always better to go with the keratoplasty and then go with the combined procedure? What are the real usage of endoscopic vitrectomies?
It's definitely useful in cases where there is a corneal trauma and your visualization is poor and you need an early intervention. And you may not have an access to a corneal graft always. So, and if you want to, and the prognosis is poor in those cases, you don't know what's happening inside. So once you go inside, you might see a badly damaged retina. So you are extending your surgery unnecessarily into the cornea, putting it back. That's where it actually helps you. So in the first assessment and performing the early surgery before the cornea gets clear completely. So you don't have to wait for that. So as I said, early intervention in trauma is most important thing. So if you delay it for a longer time, you will end up having a PVR and closed funnel retinal detachments.
From a general ophthalmologist point of view, will Berlin's edema cause defective vision? And what is the predictor of a traumatic macular hole, like spontaneous closure?
Spontaneous closure, the smaller macular holes, I would say you can wait. For most of the traumatic macular holes, I would say I don't operate within 3 months. I'll give them time. Many times the traumatic macular holes close on their own. So don't have to go inside and do an immediate vitrectomy. And it's not advisable also to do a vitrectomy with the retina, which is already damaged recently. You don't want to go inside and do that at that point of time. So traumatic macular holes, I would definitely wait for 3 months for it full closure to happen. If it's not happening, then in those cases might take up a surgery. What is the first question? Which is
Berlin's edema, does
Berlin's
it
edema.
cause defective
Berlin's
vision?
edema is uh, usually minimal trauma with minimal Berlin's edema will recover well, but there will always be a difference. There will be some amount of contrast in things, the changes which will always persist even after everything heals up. So that's difficult to predict. And you can do an OCT, it might give us an idea about what's happening to the retina on the whole. So if it is involving the whole retina and then causing outer retinal damages, then it's very unlikely for it to improve much.
Shobit sir and Lalit sir, quick questions I have for you all. So when do you consider as the primary and the secondary procedure? Say there is a retinal detachment, there is a scleral tear, and do you go in for the primary repair of the sclera and then wait for and then go in for the secondary intervention, or do you prefer to go first and then finish off everything and come out?
If there is no associated foreign body, no risk of infection, then I was just going to ask Rajeev, I prefer to do an invaginational repair wherever possible. If the wound is 5 millimeters beyond the limbus on the posterior side, and then I like to reassess the eye. Once it's watertight, I do use a little steroid also, along with antibiotic coverage in the initial stages of post-operative period, and then take a decision based on ultrasound findings. But it is a myth that one should wait for posterior vitreous separation, as Rajeev also pointed out. The earlier, the better you go in and repair. You have to, if there is a incarceration somewhere, you do a small retinectomy, whatever be the need. You're always better off with early surgery than with too much delayed surgery.
Lalit sir, your quick comments, please.
Agree with this because trauma is not one scenario because you can't generalize things. But I would, believe that if there's a detachment, I would not like to wait because these detachments will go into PVR very, very fast. So traumatic detachments, even if there is a scleral tear outside, unless it's a pre-physical kind of eye, then you have no option but to wait. But by and large, I would like to intervene in one surgery if there is a detachment. If there's a reg RD, I would intervene.
Anand sir, quickly. You are muted.
I agree. I think a lot of the principles came from our 20 gauge period of time where people were more conservative and when the machines were not as good as it is today. But today, with the equipment we have and the visualization techniques we have, I think it's always prudent to go in early. If you not just detachments, even if there is a tear and you can see, or definitely there's a foreign body, you like to get rid of everything quite quickly. So in the only event there is a small hole and maybe just like you said, a traumatic macular hole, perhaps in those situations you might just do a scleral tear repair and be done with it. But we are all pro. The earlier you get that vitreous out, the lesser chances of there being late PVR.
Thank you, sir. Everybody agrees with the same point. Thank you very much. So early intervention is always better in a patient who have RD, whether it's associated without even endophthalmitis as well.